So that's it for notices. I'd now like to just properly introduce our wonderful speaker this evening. So Dr. Chi-Chi Ekhator is a GP in London and a GP appraiser for the NHS England. She's vice chair of the Ascension Trust, which is an organisation known for initiatives that seek to help the vulnerable in society. Dr. Chi-Chi leads the AT Beacon project, and this is a health initiative of the Ascension Trust, working on the ground in the heart of neighbourhoods with key partners and stakeholders to address health inequalities. Her work has featured in a number of media platforms, including BBC Newsnight, BBC News at 6, BBC Radio 4 Food Programme, and BBC Radio 4 Beyond Relief, Doctor's Kitchen podcast, and BBC Songs of Praise. So lots and lots of different areas where you can hear about this work, but we're delighted you've all joined us this evening to hear about it at our very own Food Thinkers. Dr. Chi-Chi has several medical projects in less resourced countries and communities around the world, and was part of the Bishops of London's Health Inequalities Action Group on Interfaith Group, which is an interfaith group of leaders exploring health inequalities in the capital and how faith groups can contribute to supporting health. So Chi-Chi, we're really excited to hear about the fruit and veg prescribing work that you've been doing, and I'm going to turn my video off now and hand over to you. So thanks very much.
Fantastic. Thank you so much, Professor Christina Vogel, for that introduction. I'm going to talk to you all about a project that I'm extremely excited about, extremely passionate about. And as a GP, just that hope of how we can tackle health inequalities by prescribing fruits and vegetables. I've been a doctor for 22 years. I've been in general practice for the majority of that time. And I'm really excited about the work that we're doing right now in London. So health inequalities, that's what you've all come to hear about today. How do we narrow the gap? So my talk today will cover 4 key areas. I want to tell you a little bit about our history as AT Beacon Project, our strategic alignment, so the method in the madness, as I would say. I also want to talk about prevention on prescription for diet-related ill health. We know that we have a crisis unfolding before our eyes of widening health inequalities, especially related to food security or food insecurity. So why did we start this project? Why fruit and vegetable on prescription, and why Lambeth? So I will also delve into the program specifically to look at the entry criteria for our participants, the aims, the interventions, our partners, and also tell you a little bit about the prescription sites, why we chose those sites, and a little bit about our participants. I will then talk about our results, our feedback, and also why the delivery model is key to reach communities. So sit back, relax. I hope you got your cup of tea there with you, and let's take this forward. So the Ascension Beacon Project, what is our journey to build healthier communities in London and beyond? We are clinically driven and community conscious. If there's anything you can take away from today, just take away that mantra, clinically driven and community conscious. But we've not just popped up over the last 3 years. We've actually been working in the community for over 30 years. You will see in this picture a gentleman in 3 of the photographs. His name is Les Isaac, and he pioneered the Ascension Trust and specifically the Street Passes Initiative, which is now in 240 locations across the UK, to help communities, to help individuals to come together to be relevant to their neighbors, to be relevant on the streets, and to begin to deliver interventions that solve the crisis that societies face. So this partnership with Lambeth Public Health, you'll see Dr. Bimpe Oki on the right of the pictures. She was actually the brainchild behind the fruit and vegetable on prescription. And you'll see other key people, Jim Dixon to the left, who is part of the Lambeth Cabinet for Healthier Communities. We're all there in front of a barber shop on Streatham High Road. There's an ambulance in front of us. We're in front of a barber shop. We're delivering health. Literally, we're delivering health in innovative ways. And that's what I hope that you will hear today about the innovation to reach communities and why this is absolutely key to drive down health inequalities. So, our beacon hubs, what is a beacon hub? What is an outreach? Who are we? In this picture, you will see an army of people with expertise spanning 40, 50 years. There is a primary care nurse here, there is a school immunizations lead, there is a mental health nurse here, there is a healthcare assistant. There are people with public facing roles who have given their time to come and work with the Beacon Project to deliver healthcare in innovative ways, in strange places. You will see the community shop in the background. And our hubs are accessible to communities with unmet needs. We talk about this whole concept that communities are hard to reach. Now, that shouldn't be the case because communities are there. We want to bridge the gap. So, our whole ethos is about how do we narrow the gap. I want to also talk about our clinically led interventions and our health promotion models as well today, which are delivered with communities. Now, this is absolutely key. Now, in this picture, you will see a barber shop. Looks really strange. What are we doing in a barber shop? Now, this is all about the strategic alignment to reach communities. Now, once again, this is absolutely key. And I want to say that there is a method to the madness, an absolute method to the madness. In the corner, you'll see a GP, Dr. Jackie McLeod, who's been a GP for 30 years. Now, we want to deliver health in different ways. We benchmark our alignment to the NHS long term health plan, to Core 20 plus 5, to the Health and Social Care Plan, and to the Marmot Review Report in 2010. Now, I think that everybody should literally listen to everything that Sir Marmot says. He is my absolute guru, and he talks about preventative health and how we should do health differently. I also want to talk about the National Food Strategy. We've seen so many reports, Henry Dimbleby, we've seen Michael Gove talk about Community Eat Well program. We've talked about the levelling up agenda, but we need to strategically align our work to be clinically driven and community conscious. And we need to take that leap of faith outside our normal spheres of work and into places that communities frequent. This barbershop is a classic example. These are people I would not ordinarily see in my primary care setting. These are people who were falling through the gaps of conventional healthcare systems. These are people who were turning up in our A&E departments, who were crashing out in renal failure. So our strategic alignment is absolutely key to reach those who people have called unreachable, underserved, ignored, whatever terminology that has been attached to these people. Today, I want you to just remove that because it is possible. It is absolutely possible to reach communities that need us. So our model is we go where they go, whether that's in a church, whether that's in a mosque, whether that's on the streets of Streatham, whether that's to the bus garage. We've seen what COVID has done. And as I said, the Beacon Project was launched 3 years ago as a solution to help to address the widening health inequalities that we were seeing in some communities. We were seeing communities struck down by the pandemic, dying in their masses. And we actually knew the problem was about mistrust, and people needed to get the right information in the right format and in the right place that was accessible to them. So, I want to go on to talk about prevention on prescription. What is prevention on prescription? In this picture, you will see a renal nurse from King's College Hospital who is trying to address the widening inequalities around kidney disease and its link to hypertension. More importantly, today, I want to delve into diet related ill health and talk about the widening health inequalities around diet related in consumption. Because we know that fruits and vegetables supports healthy weight, it reduces the risk of diet related ill health, for example, heart disease, cancer. Today, I saw an article in the newspaper that talked about the widening inequality around cardiovascular disease in certain areas in London, in Barking, in Dagenham. And the figures are actually so disturbing. But here before us, we have a solution. We know that only 1 in 3 adults eat a recommended 5 portions of fruit and vegetables, that the government has said this is good for us. But we know that cost is the biggest barrier. It absolutely is a barrier. What we're seeing now is that 16,000 premature deaths are occurring that could have been prevented. We are seeing that 308,000 disability adjusted life years are affecting our communities. We are seeing that it's costing the government 74 billion a year. Now, the NHS budget in its entirety is approximately 90 billion. So, what we're doing is that we're filling up a bucket with holes in it. We're reducing our GDP by 3.4%. We're reducing our labor market by 1 million full time workers per year. Now, that could be the matriarch of a family that depends on that nurse for the family's income. That could be the breadwinner of the family that depends on on that person for their income as an Uber driver or as a zero contract worker. These are people's lives. We need to do something because families on the lowest income would need to spend 52% of their weekly food budget just to meet that government recommendation. So, why fruits and vegetable on prescription? Why diet related ill health? And why Lambeth? Now, in this picture, you will see Brixton Market. If you've never been to Brixton Market, please do go. It's just an area of diverse cultural highs and lows. Because actually, 1 in 3 people in Lambeth experience food poverty. Now, that's the inability of individuals and households to secure an adequate and nutritious diet, thereby affecting their health. Lambeth has the second lowest life expectancy at birth for males at 78.6 years. Now, that trend is affecting both males and females. And what we're seeing is that life expectancy decreases with increasing deprivation. Now, these aren't people who don't want to engage with healthy living. These aren't people who don't want to eat well. These aren't people who don't care. These are people, 81% said, according to the Lambeth data, that improving their health and well-being was important to them. So the people have spoken. What do we do? So in Lambeth, spearheaded by Dr. Bimpe Oki, the public health consultant, we took a leap of faith and we reflected on the results in America, the USA, that's been adopting this concept for over a decade. And we said, let's try this in Lambeth. Let's do this for our people. In this picture, you will see one of our hubs, which is, as I said, a social supermarket in West Norwood. Now, people who attend that social supermarket to buy food at reduced costs, so food waste that's been donated by supermarkets and different retailers, are made available to individuals who have been referred by their GPs or other health professionals or social prescribers. So it was absolutely ripe for the picking for us to launch one of our hubs in this vicinity. And you will see Hannah Dakin from the Alexandra Rose charity. You'll see Les Isaac. And in the background, you'll see one of our mental health and outreach workers here all together, holistically delivering support to our cohorts. Now, this is co production in its finest, co production with local partners, co production with key leaders in the community, and co production with communities. Now, we know that 24% of households of non white ethnicity are food insecure. 15% of households in the UK are food insecure. The most deprived communities suffer disproportionately from much higher rates of disease, from diabetes to obesity to cardiovascular disease, you name it. We are seeing our hospitals filling with people that could have been served elsewhere. In the picture on the right, you will see myself and a primary care nurse in a mosque reaching out to women as part of their women's group, prescribing health, prescribing lifestyle. So let's think innovatively, let's think outside the box. I'll now delve more into the fruit and vegetable on prescription pilot in Lambeth, which ran from October 2022 till the end of March 2024. In this picture, you'll see one of our traders, an amazing lady who really knows her clients, who really knows her punters, so to speak. And that is part of health. That is part of the holistic support that we bring around people. It's not just a transaction with vouchers, it's about following the client from the time they see us in the AT Beacon project to the marketplace and back to us. So, the entry criteria for the cohort that we supported during this pilot was two key things: socioeconomic status, so that is those experiencing low income, and we also looked at it through a clinical lens. Now, this is really key because we have the data, we know the statistics, we know exactly who to target. So we decided to target those with hypertension or a risk factor for cardiovascular disease or hypertension. Our aims were to promote healthy living, healthy eating, and lifestyle. We also wanted to give participants a sense of agency, a sense of dignity to be able to choose, have personal choice of the fruits and vegetables that they consume and put into their body. We wanted to also develop these individuals as health ambassadors. In medicine, we have a terminology: see one, do one, teach one. Now, what we wanted to do was to empower these individuals to be able to check their blood pressures, to be able to, just be able to reflect on their own health and well-being, and perhaps feel confident to take this gospel of health into their communities. See one, do one, teach one. In terms of the interventions we offered, the fruits and vegetable vouchers were given to participants on a weekly basis. So that's £8 per week for each participant, plus an additional £2 per week for each household member. And in exchange for the fruits and vegetable voucher, we use the carrot, so to speak. We would require the individual to have a blood pressure check. Once again, this isn't a clinically necessary procedure, but what we felt was quite necessary was just to have that person sat in front of a clinician for 10 minutes or so that we can then be able to deliver another range of interventions, another holistic package. We also delivered a very bespoke standardized health questionnaire whilst they sat in front of us at key intervals during the program. Now, this questionnaire targets 7 key areas to do with activity levels, blood pressure awareness, cancer screening, their uptake. Do they go for their cancer screening? Their diet, diabetes risk, eye health. Do they go for their routine eye health appointments? They're diabetic. Are they engaging with healthcare? We also wanted to target areas around stress, substance misuse, and other issues that clients may be facing. We also wanted to ensure that everybody was plugged into primary care. So GP registration was key as well. And the final intervention that we offered was a very bespoke 8-week voucher weaning program. Now, we know that participants had become reliant on vouchers as a means to an end, but actually, we can't change their living circumstances. We can't shift the narrative. But what we can do is to help them to feel more resilient, more food secure, to become more aware of all the sources of support in Lambeth and the locality that could help them. We could help with housing needs and signposts, and we could help with finances and budgeting. So this was a very targeted program around their wellness goals, involving motivational interviewing and ensuring that we make every contact count throughout the program. Our partners were Lambeth Public Health and the Alexandra Rose Charity. Now, where did we prescribe? How did we do this? Everyone keeps asking, how did you do this? Well, we were already working in Lambeth. We were already working in Southeast London since the pandemic. We have very deep rooted networks spanning over 30 years. But we chose 2 sites, 2 key sites. So the community shop in West Norwood and St. John's Church in Angeltown with a local inner city estate unit as a secondary site within Angeltown. Now, if you know Angeltown, it's hit the headlines for various reasons over the years, but there is a lot of socio-economic challenge around, people's income levels, around youth violence as well. So we knew that this was an area that perhaps people may feel reluctant to go and deliver a pilot in, but we were there, we did it, and we're still there. So, in terms of the total number of participants, we supported 54 participants for an average of 12.5 months over the 18-month period that the pilot ran. Now, some people dropped out either due to various reasons, perhaps moving away from the locality. Some people are living in temporary accommodation. But on average, each participant was supported for 12.5 months. The age range, average age of 49 years old. So the age range was between 21 to 85. So we supported the full spectrum of age. In terms of gender, there was more females. Absolutely. 91% were supported in terms of females, and 5% or 9% of males. Ethnicity wise, we supported individuals, 59% were Black African, 30% North African, 7% white, and 4% Asian. So I come back to this mantra: clinically driven and community conscious. You will see us as we're about to launch the project with our partner community shop. We're very excited, very nervous. How do we do this? Will it work? It works in America. Will it work in the UK? But we knew that we needed to reduce food insecurity as the cost of living crisis took its grip. We knew that prevention is better than cure. And there was a need for a healthier diet and a need to capture that multi generational opportunity to not only impact the participant, but their families, their partners, their communities. Now, that's what the government wants us to do. The government wants us to improve health in line with government guidelines. So we did. We wanted to improve both physical and mental health. We wanted to support the NHS because we knew the NHS is carrying a lot of weight. There is a long waiting list. People are asking questions: how do we solve this problem? And we thought, well, let's have a go, let's try. We wanted to support people to engage more with local support options and groups. And we wanted to support the local economy because the vouchers are used in the local markets. The vouchers are used with local traders who've been there for decades. It goes back into the communities. And we see the local traders as real key partners because they too get to know these individuals who were mere statistics, who were called hard to reach. They too know if they haven't come this week to buy their okra or their spinach, and they too ask the questions. And we began to ask ourselves the questions: how can we bring more support? How can we ensure that the money is directed into these key partners? And how do we ensure that people shop in these areas as opposed to low cost, unhealthy food outlets, which we all know are prevalent in communities with socio-economic challenge? I'd like to now talk about the final results of the pilot. And this was so encouraging for me as a GP. It was so encouraging to take this leap of faith and actually see that the numbers did not lie. The first thing that we saw a reduction in the number of people with high blood pressure. So, as I mentioned, we had a cohort of people who had risk factors. So, that was our preventative lens. And we had a cohort of people who had an established diagnosis of hypertension. And by the end of the project, we saw 20% fewer clients had high blood pressure. So, a blood pressure in the range that was unsatisfactory. Secondly, we saw a reduction in the mean blood pressure. Now, these figures have been benchmarked by the public health data intelligence team at Lambeth Public Health. And we saw a reduction in the mean blood pressure of the whole cohort. But actually, what was really exciting and encouraging, and apologies for my excitement, is the geek of a clinician in me. But I was so excited to see that we had a statistically significant reduction in the mean blood pressure of the high blood pressure cohort group. Their systolic blood pressure decreased by 13% and their diastolic blood pressure decreased by 11%. Now, this is absolutely amazing, and it just makes me think, how much more can we do? These are just 54 clients. How much more people? How many more people can we support to drive down those numbers? And I just want to say that also what we need to understand is that a lot of these people wouldn't have engaged in healthcare services for various reasons. It could be access issues. They might not have the bus fare to go to hospital appointments. They might be working zero contract hours. Sometimes these situations are completely outside of their control. So, by providing our services in places that they would frequent, it gave them that opportunity to work on their health, just to take that time out for themselves because they're so busy working hard, caring for other people, that they rarely have time to address their own health needs. And so, what we saw was a redemption rate of our fruit and vegetable vouchers of 96%. Just park that figure in your head. 96%, that's huge. And actually, the Alexandra Rose charity commented that this is one of the highest, if not the highest, redemption rate that they've experienced in their program thus far across the United Kingdom. So, going back to the results and the opportunities for improving health and well-being, what we also saw was that a third of clients did not check their eye health at all or checked it seldomly. So we began to use this as an opportunity through the pilot to engage people back into the system. And by the end of the program, we saw a statistically significant improvement in engagement around attendance for routine eye health appointments. What we also saw is that a third of our participants did not engage with cancer screening at all. So these are routine call ups for cervical cancer screening or perhaps breast screening. More than a third didn't engage. Once again, there are many reasons around that. But by the end of the pilot, what we did see was statistically significant improvement in the uptake of cancer screening. Once again, what we saw is the burden of the stress of being food insecure, financially insecure, being at the bottom of the rungs in society. A third reported mood dysfunction. And once again, by the end of the project, through the support that we brought around our participants with access to a mental health and outreach worker attached to our project, we saw an improvement in mood and well-being. So what we reflected on was the opportunity for targeted health promotion and intervention. And using our standardized health questionnaire, we made every contact count every single time. So, in terms of feedback, and there is so much to say, so much to reflect on, but I just wanted to bring forward some of the voices of the participants because often these voices are unheard. Often these voices cannot speak truth to power, so to speak. But people are saying, if I had the opportunity to eat healthily, I would. But as it is, I don't know what it will be after the program ends. Another person said, the fruit and vegetable program has impacted my health positively. I wish it would continue. Another person said, I now buy things that will contribute to bringing my blood pressure down. Someone else said, it's not just about the vouchers, it's about the lifestyle, it's about the AT beacon, it's about what they're doing, especially around our mental health. All that energy comes back to you. You guys are doing extra. Now, these are people that we don't often hear from. These are people we may never see in the usual space of primary care or perhaps secondary care until it's too late. But they have a voice and they have a solution. And that's why it's so important to co produce with healthcare, being clinically driven and community conscious. So the model is absolutely key. It does matter. It absolutely does matter. And in this picture, you'll see a range of individuals. To the left is Dr. Charlotte Ndelu, one of my GP colleagues on the Beacon Project who leads our Sunday outreach program. In the middle, you will see actually one of Professor Christina's mentees, who is a student of the MSc in food policy at City University, and is also one of our key food ambassadors on the project, delivering our weaning program. To the right, you will see Dr. Jackie McLeod, a GP for 40 years, who has wealth of experience in clinical commissioning in Southeast London in public health, and also out of hours as a key director for CellDoc. You will see Margaret, who's been a GP primary care nurse for over 40 years, lived in Lambeth, works in Lambeth, schools, everything. She has the knowledge of the community. You'll see myself in the background. You'll also see Grace, who is a mental health nurse by background, but after retirement came back into the workforce to work for us as a mental health and outreach worker. And you'll see Peter in the background, who has been working on the railways for over 40 years, born in Angeltown, grew up in Angeltown, knows the communities like the back of his hands. So there is a method to the madness. There is that cohesion of clinical drive, but community consciousness that we need to bring to programs like this. We need to recognize that people want trusted local networks, national networks in communities, which we have. We've done this for over 30 years. Communities want you to co-produce with them. They don't just want things done to them. We need to understand what they need, where, how, and when. And we need to deliver with local partners and in local places to strengthen the prevention offer that we can deliver as the NHS by building on existing initiatives in local systems. Our success was also because we're clinically led, and we were able to target our this program towards those whose needs were not met by conventional healthcare systems. The success was also built on the holistic support that we gave participants on a weekly basis to check in with them. We were able to ask them, "How are you?" Because nobody else might ask them, "How are you? How are you today?" And we were able to deliver a personalized 8-week resilience building program at the end of the pilot to support each participant's food security, their health literacy, their well-being goals, and their financial and housing security based on their needs assessment. We actually asked them, what do you need? What do you want this workshop to look like? And beyond the program, we're still able to offer ongoing access. We don't just do things to communities and leave them, we're still there. They can come through our doors, through our hubs, anytime they like, and we're there to support them beyond the program. In this picture, you will see Hannah from the Alexandra Rose charity delivering part of the workshop around nutrition. The room was absolutely full. The atmosphere was electric. People were asking their questions. We were all excited together, co-producing health with communities. Communities want to ask questions. They are interested. In fact, we didn't have enough space for all the participants in the room, but you can see from their feedback what a lifesaver the Rose voucher has been for them. They can afford to buy a variety of fruits and vegetables from their families. They never used to buy fruits and vegetables, but now they do. We were able to give them cookbooks, which Lambeth had authored specific to diverse and cultural needs. And we were able to see that by eating fruits and vegetables, people felt healthier in their weight, in their well-being, and in their whole person. And finally, I just want us to reflect on all that we've heard today and all that perhaps we're going to hear in the future as we speak to government, as we speak to the NHS, because they're the ones saying this is what we need. We need more prevention. We need to put more money into prevention. We need to put our money where our mouth is, so to speak. So hopefully this will be a model that can be built on, that can be expanded, that could be scaled up, because we absolutely know that the food we eat is vital to our health. We absolutely know that people are struggling with food poverty and food related health. And today I'm speaking for those people Because at AT Beacon Project, we do understand the importance of trust. People feel that they've not been heard. People feel that people don't want to reach them, but they can be reached in innovative ways to support those who have fallen through the cracks of healthcare systems because of inequalities in accessing health and well-being support. And finally, I want to say that change is possible. I've seen it before my eyes, it's possible. And we see the fruit and vegetable on prescription project making a significant difference to the health of people in our community. But we need to be clinically driven and community conscious. Thank you.
Excellent. Thank you so much, Dr. Chi-Chi. What an impressive, wonderful presentation that you gave us there about all the very, very wonderful work that you're doing, and really speaking for the community, that you're working with and all your colleagues. I can absolutely see it's been a huge team effort. You certainly do make the case for a holistic approach to prevention, and also follow that up with incredibly impressive results, those blood pressure results, and also the redemption rate results of the vouchers are incredibly impressive. So thank you so much. There's lots of really positive comments in the chat, or everyone saying, what an amazing piece of work that you're doing. So I'm now going to go through some of those questions, if you're okay. We've got about 20 minutes now to work through a lovely long list of questions. So please do keep them coming in. Eleanor Boyle has said what amazing work this is, and how great it is that your program specifically targets food habits, and that this is really great. We've got a question here from Seth Cook, who's asked specifically where the funding for this program came from.
So Public Health approached us in 2022, having worked closely with the Alexander Rose charity in their children's centres, and sort of married the two together. The Alexander Rose charity obviously received funding from Impact on Urban Health, and we were able to use some of that funding from the Alexander Rose charity to deliver this. So combination of funding from Public Health and other key partners.
Again, showing how resourceful you are. And I'm guessing that funding has now come to an end.
We are at the point where we are reimagining the next phase. So we are in a very exciting juncture, and we're dreaming big.
Excellent. Well, that's great. So that links to a question now from Laura Lane, who says these results are so impressive, and it does make such a strong case for policy intervention to widen funding and participation across the UK. So she says that your excellent engagement suggests that the strong local partnerships and relationships and long-term activities you described play a part in the success of the intervention. And what would be your recommendations then for widening this kind of program across the UK, especially in areas that lack the sort of community support and fresh project markets that you describe that are available in Brixton?
I think that I do absolutely agree that in terms of local traders, they are at risk. Their whole livelihood is at risk from larger competitors. And that's something that this project should really support. In terms of upscaling the project to other regions, I think it's important to take some time out to really look for those local partners that you can build such a project on. And that's exactly what Public Health did with us, because we had already been working in the patch across Southeast London. We already had 6 hubs in Lambeth. And so it was quite natural to be able to bring this partnership together. And I'm sure that there are lots of people across the country doing great work. But once again, we as Ascension Trust, we do have a presence all across the UK. And so we're excited about the prospect of scaling this up outside London using our existing networks.
That sounds very exciting. That is excellent. And I really like that link there about how the fruit and veg vouchers are being used to build local businesses and support healthy businesses locally. That's a really neat sort of feedback loop. And links to a question then from Basil Verdeau, who said, he just wondered what the response was from participants when they found out that there were only a couple of locations that they could use the vouchers. And did any of them expect that they should be able to redeem them at supermarkets or more widely across retail outlets that they have access to?
Now, that's a really great question. I think that understanding how people engage with the local economy is quite key. So, in terms of the sites that we delivered this project in, so West Norwood, we have traders who accept the Rose voucher. In Brixton, there are several traders that accept the Rose voucher. So, we did have to take into consideration access issues for people, especially if you remember that lots of people may have other issues as a result of their diet related ill health, disabilities. So that was absolutely part of the planning of the program, that people could be able to access traders. In terms of the question about people wanting to use these beyond the local traders, a few people did inquire around that, but actually what we saw was an overwhelming response of positivity of being able to access culturally diverse food in the local traders that you can't obviously buy in the market. There are some staples that just aren't available, and what we did want to encourage, we wanted to encourage participants to go back to their roots, so to speak. Go and cook all those lovely foods that you enjoy. Take time out to make it, batch cook it, and feed your family and feed them well. And actually, the market is a great place. I mean, I am a bit biased, but it is a great place. And we found that people received the whole concept really well.
Yeah, and I can see how that links into the mantra of, community consciousness. So,
Mm,
and I can see how that almost one of my questions actually was about the impressive results that you did see, and how much do you think is attributed to diet, or how much do you think is attributed to reducing stress, improving well-being? They're all closely linked to blood pressure, and it'd be great to just get your sort of anecdotal clinical expertise on what you think made that difference.
yeah, yeah. That's a really interesting question, Christina, because we shouldn't underestimate the impact of stress. In fact, I was reading an article today. I think today I was had my head stuck in various articles of the impact on stress on blood pressure and well-being. It was actually an article about mindfulness and meditation, and how it clinically reduces some markers related with ill health, such as blood pressure. So it just points to the fact that a lot of people are under pressure, and stress can drive a lot of diet related ill health and worsen existing underlying conditions. We know that there's evidence that points to that. So that needs to be built into the whole program. How do you address this alongside diet, alongside the causes of stressful factors? So as a clinician, we are really well versed in knowing that the causes of ill health are very much interrelated. Physical health impacts on mental health. So when we see someone with a long-term condition, make sure you're looking at them through the lens of the psychological burden that they're carrying. So it's difficult to attribute which caused what, but I think the key message is that all of it is important, not just the diet, but the whole thing. And
And
looking at, yeah,
that holistic approach, isn't it? Yeah, and
absolutely,
food
absolutely,
insecurity is exactly the same. It's a stressful situation.
it
Yeah,
is.
absolutely. Alicia Weston has a question. Has the analysis been done on the split of voucher use between fruit and veg?
That's a really good question. I will take that question back to the Alexandra Rose charity, actually, because that might be an area where we're able to home in on some more. Because what we can do is track the vouchers. So as soon as somebody receives a voucher, there's a barcode, and we can track where that's spent. But I'm not sure if we're able to track how much, fruits was purchased or vegetables, but that's exciting. We will definitely reflect on that and see how we can build on that.
Excellent. Tom Pearson has a similar sort of evaluation question. Has there been a cost versus benefit analysis of your 2-year program? And will this be a cost that NHS or local authorities will pay for in the long term?
I mean, I think that if we reflect on the costs of this in the grand scheme of the high, the top figures that I've mentioned, in the sense that the NHS budget is 90 billion a year, and we are spending 74 billion on diet related ill health. Obviously, this project is a minuscule amount in comparison to those high figures, but the results that we have speak volumes. Because if you can imagine the sorts of things we've prevented, if somebody was to end up in hospital with a stroke as a result of undetected hypertension or a heart attack, that costs thousands and thousands and thousands of pounds to the NHS. But this was just a pilot. It was just a sort of time-bound step into the unknown in the UK. It's the very first of its kind. But as we build on the next phase, we hope to obviously break down these numbers a little bit better.
Absolutely. And for a proof of principle sort of pilot, it's,
Mm,
impressive results. So absolutely, we hope that it will be rolled out, and a more thorough evaluation can be
mm.
conducted alongside. There is a question here from Sally Morgan. Great work. Did you explore impact on any other family members of the participants, like their children or other people they were caring for?
That's a really good question. I think that what we did see was some qualitative feedback. And we did receive a lot of qualitative feedback, a lot of quotes, a lot of videos from participants describing the impact on their families. We heard single parents talking about how they were now able to give their children more fruits and vegetables that they perhaps wouldn't have been able to. So there is a lot of qualitative feedback that we have been reflecting on. In terms of quantitatively, how has it impacted a family member's health? We haven't gathered that deep level of information yet, but that's something we hope to reflect on in the next phase of the project. But we do know that it did impact a lot of community members. And in fact, the weaning workshop, or the workshop at the very end of the pilot, was open to participants and their families. And people did come along who weren't the primary recipients.
Yeah, absolutely. I mean, and that qualitative feedback is very important. And we
It
hear
is.
very similar feedback around a healthy start.
Mm,
How much it can change dietary patterns. But as you said, the quantitative data is important as well. So Claire Jude said has a question. Did all the participants have what they need to use the fruit and veg? For example, that they're rolling out similar projects and approaches in Cornwall, but finding that there are sort of needs around cooking equipment or
mm,
potentially cooking skills, and just wondered whether there were any other things that you found out about what might be needed to use the fruit and veg.
mm. I think that we had a head start in the program, in the sense that we had already been based at the hubs for a good year and a half before that. So we knew a lot about our participants and their unique needs. So, for instance, some had already been supplied with a blood pressure monitor. So we made sure that by the end of the pilot, each individual had a blood pressure monitor. In terms of specifically about cooking tools and so on and so forth, because the people that attend our hubs may be from low income backgrounds, they were supported in other ways by other agencies that work alongside us in the hubs. So it is a sort of multi-center approach to support participants. We might not personally have been able to deliver the support they needed, but if we did see that there was a gap, we could refer on within that hub or within that locality. So once again, it's about joined up approach, because it could be actually what they needed were clothes for their children. And once again, we had that whole holistic support that we were able to signpost people to. And in terms of cooking, Lambeth had already published a cookbook that we supported people with and went through it with them, and cemented that at the end of the program also.
Yeah, absolutely. I mean, it's fundamental, that sort of connected approach, and excellent the community partners you had. We've got
Mm.
quite a few people saying excellent project, really want to see the results. We want to share them across local authorities. Will they be published anywhere, or are they already currently available?
There are some reports already available. So there are two key reports available. So the Alexandra Rose Charity has published two reports, one last year entitled A Small Scale Study, and I can put that in the link later. And another report is due to be published this week. It may have gone, out yesterday, from I believe with the Alexandra Rose Charity and perhaps with Sustain as well. So two reports are out, and our own report from the clinical lens is due out in the next 8 weeks.
Excellent, excellent. So can we they be accessed via the Alexandra Rose website or?
Absolutely, yes, they should be. They should be.
Excellent, that's great. So we've got a bit more of a systems question from Jonathan Lodge, who says, with so many cost pressures and food price inflation, what can we do to persuade the government to focus on related R&D cash to reduce the cost of food, particularly fruit and veg, rather than spend it on sort of smaller scale projects?
Mm. I think that in terms of reflecting on that question, the thing that comes to mind actually, we did a webinar yesterday with Sustain, and it was really focused on how do you reduce the cost of organic food and the processing around that so that it can be more accessible and affordable for communities that need it. So that's definitely a key thing that I really want to highlight because we know the benefits of organic and eating whole food. So that's one area that could be targeted to make sure that everybody has equitable access to the best for them and for their family. So that's one particular area. In terms of focusing money to reduce costs of foods, I think there are elements that are not within the control of certainly myself as a GP. But what I can bring to the table is about strengthening the preventative offer that the NHS and governments really need to reflect on because they've said it. They've said it in Henry Dimbleby's report. They've said it in, Sir Michael Marmot keeps talking about it, and hopefully people are listening to him. And we've said it, Michael Gove has said it, leveling up agenda. We know it works and we just need to get behind the evidence and deliver. And that's what we've done.
Yeah, absolutely. You're quite right. There's lots of commercial imperatives that are driving us in a different direction. But back on sort of your comment around organic farming, Tom Pearson says, do you think there are opportunities for programs like these to more closely link not just with local markets, but potentially with city fruit and vegetable farms or regional fruit and vegetable farms if it was to be rolled out more regionally?
Absolutely. I mean, I absolutely love these questions because it's just whetting our appetite. And that's exactly the whole point of this discussion. We need to think big. We need to think outside the box. And it's a yes from me. Absolutely. I say yes, it should work. It can work. Let's have a go. Let's do it.
Yeah, absolutely. And there's a few questions around sort of sustainability of the program and potential for assessment, longer term assessment of your participants and whether they sustained behaviour change, whether the blood pressure change was sustained. Just wondered
Mm.
if you had any sort of comments or thoughts on I guess it's funding dependent, but what your plans might be to continue to follow or engage with participants.
Absolutely. Obviously, without letting the cat out of the bag, so to speak, we do have a very engaged MSc student from the Centre for Food Policy, who is one of your students, Christina, who is going to deliver that approach for us as we reflect as part of her dissertation on the fruit and vegetable pilot in Lambeth. And this is exactly what we're going to do. I don't know which bits I can speak about, Christina, and which bits I can't speak about because we're going through the ethical approval process, but it is in the pipeline and we are excited about this. And we're excited about the fact that we have ongoing access to all these participants. They haven't disappeared in the thin air. We still see them, they still visit us, and we can absolutely track them.
Yeah, it is. It's very exciting, an exciting
It
piece of
is.
work. So
It
we're
is.
delighted, yeah, for the link as well. So that's really great.
Mm,
I just had two last questions. So one was whether or not, I guess it's linked to Laura Lane's question around the holistic approach upscaled sort of beyond the Ascension Trust. And what do you
yeah.
think that would require for this to be really seriously rolled out across England or the UK?
I think it will require the right level of funding. It will require, and I say that because as part of our work in Ascension Trust, and we come from a very sort of philanthropic lens also, we give above and beyond. And so we wanted to just partner and help in any way that we could. And we delivered above and beyond. But to sustain this type of project and get the right level of impact, it does need to be properly resourced. You do need to have a skilled workforce who are trusted locally, and you do need to co-produce with communities, and people do need to have ongoing access. And so we do need to reflect on what is actually the true cost of this type of work, because I'm sure there are many people who share a similar passion that I do across the country who absolutely want to do this, and we should empower them to do it for themselves and for communities across the country.
Yeah, absolutely. Absolutely. Well, thank you, Dr. Chi-Chi, so very, very much for sharing your learnings with us all today. We've had an excellent audience and a really engaged Q&A session, and there's lots to be taken away from the excellent work that you're doing. So thank you very, very much for joining us. Everyone, this recording will be available on our YouTube channel, the Centre for Food Policy YouTube channel, so you can catch up with it if you had to step away or if you want to share it with others. So please do share widely, and don't forget to tweet about our Food Thinkers Tonight and the learnings that you've had from Dr. Chi-Chi on X. And please do use the hashtag Food Thinkers and the handle at Food Policy City. I just wanted to flag again that our next Food Thinkers will be on the 19th of June with Dr. Matthias Magalus from the University of British Columbia. So watch out next week for the registration for that. But Dr. Chi-Chi, thank you very, very much for a truly magnificent Food Thinkers Tonight.
Thank you so much, Christina.
Thank you. Bye-bye.